Good day, everyone. I am Dr. Messina again. This is another topic that is important for you to know. I'm sure you will encounter at least one patient who will need transfusion in your medical career. And any doctor will know how to transfuse, but the wiser doctor should know when not to transfuse. So, as a definition, blood transfusion is the infusion of whole blood or blood component in a patient. The main indication of blood transfusion are first to improve oxygen carrying capacity and blood volume, that's for red blood cell or whole blood. Second, to improve hemostasis, and that is for platelets and plasma products. And third, to improve leukocyte function, usually given by the granulocyte transfusion. Okay, let's have a head count here. Who among you donated blood already? Okay, so I hope you would increase your donations, especially now that we are on quarantine. There are really low percentage of blood donors during this time. So this figure will show you the usual pathway when whole blood is donated and separated into components. From the whole blood, it can be divided into PAC-RBC by centrifugation, platelet, concentrate, and plasma. While plasma can be further separated to cryoprecipitate and other derivatives. Okay, how do we do transfusion? Gone were the days wherein we transfuse whole blood or fresh whole blood. The practice that we are encouraging now is blood component therapy. It is where the patients are best treated by the administration of a specific fraction of blood that they lacked. What are the values of blood component therapy? Patients who are treated with specific component that they lack will avoid risk of sensitization to other blood components. So, for example, the patient has thrombocytopenia, severe thrombocytopenia with bleeding, but hemoglobin is in an acceptable level. The prothrombin time and APTT are also normal. White blood cells are normal. Hence, the patient needs platelets. Okay, it's better to transfuse only platelets, either platelet concentrate or platelet pheresis, in order to avoid what we call alloimmunization. When you say alloimmunization, it is where a patient is not more responsive to transfusion therapy because of the formation of alloantibodies that destroys the future cells that will be transfused to the patient. Okay, so we don't want this. Second, the proper use of component therapy can result in potential treatment of many patients with blood obtained from one donor. So if we use blood component therapy, one donor, there are several patients that can already benefit from it. So actually there can be at least 3 patients that can benefit if we will divide it into PAC-RBC, platelet, and plasma component. Third, use of components can result in effective transfusion therapy with reduced risk of volume overload. So in patients with risk of volume overload, especially those with congestive heart failure or renal failure, they would want the least volume of blood to be transfused in order to not to have pulmonary congestion. So a whole blood is equivalent to 450 to 500 ml. But if you only transfuse what the patient needs, like for example, PAC-RBC, that's only equivalent to 250 ml. Okay? Let's go to the specific blood components. First, we have PAC red cells or PAC-RBC. It is separated from whole blood by centrifugation, and 1 unit PAC-RBC raises the hemoglobin by 1 gram per deciliter or 10 milligrams per liter, and the hematocrit by 3% in an average size adult. So for example, the patient's hemoglobin prior to transfusion is 7 grams per deciliter. After 1 unit, you expect that to be 8 grams per deciliter or 80 milligrams per liter. And PAC-RBC also restores or maintains oxygen carrying capacity with the least volume. How does one arrive at the decision to transfuse? This is a very important question. To transfuse or not to transfuse? Assess the need for red cell transfusion properly. It's not just the numbers. We don't only base it on hemoglobin and or hematocrit, but also evaluate the patient's symptoms and the physiologic assessment of the patient's functional capacity. So for example, in young patient with no cardiovascular disease with very mild symptoms, we reserve transfusion, okay? We defer transfusion in these patients compared to elderly patients with cardiovascular disease and with severe symptoms such as chest pain. Or there are a lot of factors for the development of symptomatic anemia. So iba-iba yan kada tao because it is dependent on the rapidity of onset of anemia, wherein the faster the drop in hemoglobin, mas lalong symptomatic yung patient because the cardiovascular system is unable to compensate. Second is the severity of anemia. So, mild anemia, moderate, and severe anemia, usually severe and moderate would have symptoms. The age of the patient, young versus elderly patient, the presence or absence of cardiac or pulmonary disease, okay, and the presence of comorbid disorders like liver disease, endocrine disease, hyperthyroidism, and also renal disease. Actually, the lower limit of human tolerance to hypovolemia is not established, but they say at hemoglobin of 7 grams per deciliter and higher, oxygen delivery is believed to be adequate. So in healthy individuals, tissue oxygenation is maintained and anemia is tolerated at hematocrit as low as 18 to 25%. So that's about 18, about 50, 45 to 50 hemoglobin up to 75 hemoglobin. And then the heart does not produce lactic acid until the hematocrit reaches 15 to 20%. Third, heart failure does not usually occur until hematocrit reaches 10%. So with the above values, you will see that the cardiovascular system is efficient in compensating for anemia, and only a few patients would need transfusion support if their anemia has a reversible cause. For patients with chronic anemia, so pag chronic anemia, ibig sabihin, usually they are congenital anemia, hereditary anemias, anemia of chronic disease, okay? The significant symptoms does not appear until there's 50% reduction in red cell mass because the cardiovascular system is able to compensate. So what are the guiding principles for elective transfusion in anemic patient? 1. Determine the nature of anemia or the cause of anemia. If there's a reversible cause by pharmacologic intervention, then you may address this first before transfusion. Second, determine which symptoms will be alleviated by transfusion and consider alternative therapeutic intervention when available. So for mild symptoms that are relieved by rest, then you can just do pharmacologic intervention first and while waiting for the hemoglobin to rise. You may not need transfusion in mild symptoms. Third, avoid an empiric automatic transfusion threshold or transfusion trigger. Okay. In the olden days, the doctors tend to use a transfusion trigger of 9 grams per deciliter, but this is discouraged and um, would factor in the symptoms aside from the hemoglobin and hematocrit. Fourth, anticipate the need for autologous blood transfusion. Discuss all risks and benefits with the patients. So, remember the transfusion comes without risk, comes with risk of adverse reactions like allergic transfusion reaction, febrile non-hemolytic reaction, which is the most common transfusion reaction. And administer transfusion on a unit-by-unit basis. So, it means that do not reserve 3 units immediately because it's very difficult to look for blood components nowadays. You have to evaluate if the symptoms of anemia was already relieved by just 1 or 2 units. So don't waste blood. That's the takeaway message of this slide. Again, additional guidelines would be transfusion is indicated for symptomatic anemia regardless of hemoglobin level. So if there are moderate symptoms of anemia, then even if the hemoglobin is 9, then you have to transfuse. What are these symptoms that are significant? Syncope, wala na malay, dyspnea that is pertaining to, or dyspnea wherein the cause is anemia, postural hypotension, tachycardia, angina, and transient ischemic attack. Second, transfusion is rarely indicated for hemoglobin more than 10 grams per deciliter. Almost always, it is indicated if the hemoglobin is less than 7 grams per deciliter, especially if acute in onset. And third, for values between 6 to 10 grams per deciliter, decision is based on the presence of risk for complications of inadequate oxygenation. So, don't just base it on numbers. Treat the patient, not the number. Okay, there's what we call autologous blood donation. Although mas madalas yung allogeneic blood transfusion wherein the blood comes from other individuals. For autologous blood donation, the blood came from yourself, kaya nga auto, no? These are used in patients who will undergo surgery, but they have adequate hemoglobin and hematocrit. So, these are the things to do. There's pre-operative collection wherein blood is drawn and stored prior to anticipated need. The perioperative collection and administration, the patient should be acute normovolemic hemodilution. The blood is collected at the start of surgery and then infused during or at the end of procedure. Pwede ring intraoperative collection wherein shed blood is recovered from the surgical field or circulatory device and then infused back to the patient. Pwede ring post-operative collection wherein blood is collected from drainage devices and reinfused to the patient. So these are the ways wherein they could do autologous blood donation. There is more leniency in transfusion of PAC-RBC given to patients with risk of intravascular volume depletion. So these patients are at risk for myocardial infarction, such as those with coronary artery disease, valvular heart disease, and congestive heart failure. Also for patients at risk for cerebral ischemia, there's history of transient ischemic attacks and previous thrombotic stroke. So sila yung medyo hindi tayo strict sa transfusion requirement nila. So for transfusion guidelines, we use the 2018 Frankfurt Consensus Conference wherein this is an international consortium of scientific organization in the field of blood transfusion. It includes American Association of Blood Banks or AABB, International Society of Blood Transfusion or ISBT, and the European Blood Alliance EBA. So marami pang ibang mga organizations ang nagtulong-tulong to make a consensus guideline, and these are the things to remember for PAC-RBC. All throughout, we are promoting restrictive red blood cell transfusion versus the liberal RBC transfusion. Okay? When you say restrictive RBC transfusion, mas matipid ang pagsalin ng dugo. So, for critically ill but clinically stable patients in the ICU, the transfusion threshold is less than 7 grams per deciliter, and that is based on strong recommendations by randomized clinical trials. For patients undergoing cardiac surgery, a restrictive RBC transfusion threshold also is being recommended with a hemoglobin of less than 7.5 grams per deciliter as a threshold. How about in patients with fracture and cardiovascular disease or other risk factors? The hemoglobin transfusion is less than 8 grams per deciliter. How about in patients with acute gastrointestinal bleeding, which are hemodynamically stable? So the threshold is 7 to 8 grams per deciliter before you would consider transfusion. Okay? There are times when blood products are treated with additional techniques to remove unnecessary elements or contents. So we call that leukocyte-reduced blood products. We do this for the prevention of the following adverse events. One is febrile hemolytic transfusion reaction, or FHTR. Remember that this is the most frequent reaction associated with transfusion of cellular blood components because of the presence of leukocytes or inflammatory mediators. It can trigger development of fever. That's why in patients with previous history of blood transfusion reaction, then we recommend giving pre-medication with paracetamol. Okay? Second, we want to prevent HLA alloimmunization. This is defined as the formation of antibodies to non-self red blood cells and platelet antigens, causing refractoriness to platelet or RBC transfusion. So remember, these two, febrile hemolytic transfusion reaction, most frequent reaction during blood transfusion, and HLA alloimmunization, wherein there's formation of antibodies, so ayaw nang tumaas yung platelet or PAC-RBC. Okay? Platelet refractoriness is because of HLA alloimmunization, or there can be CMV infection if the patient are full of leukocytes. Okay? So what do we do to the blood products? They can be washed, they can be centrifuged, freezed, or the use of leukocyte filters when transfusing. So look at the picture. Ito yung bilog dito sa picture. This is the leukocyte filter used in PAC-RBC or platelet transfusion. It significantly reduces the number of leukocytes, okay, in these components to reduce the risk of HLA alloimmunization or transmission of CMV infection. It also reduces the incidence of febrile non-hemolytic transfusion reaction. But the limitation is that it's costly, so it's additional around 4,000 to 5,000 per transfusion to patients. Another way to reduce leukocyte is irradiation. Gamma irradiation to inactivate viable lymphocyte operation within the component can be achieved, and this is for the prevention of TAG-VHD or transfusion-associated graft versus host disease. It's not indicated for the prevention of febrile non-hemolytic transfusion reaction. So, pag you're transfusing irradiated blood, you are destroying the viable T lymphocytes that can cause TAGV. Next, we have washed packed RBC. It's also a special treatment for packed RBC because by washing them with sterile NSS, more than 98% of the plasma proteins, electrolytes, leukocytes, and antibodies are removed. So this is the most commonly requested special treatment to blood products because it's simpler to do than, irrigation. Mas mura din siya than leukocyte filter. It is used to prevent allergic reaction, especially in IgA deficient patients or recipients at risk of hyperkalemia, newborn and intrauterine transfusions, and it's also used in transfusion for patients with paroxysmal nocturnal hemoglobinuria or PNH. Okay, let's go to whole blood, also known as fresh whole blood. The volume is about 450 to 500 ml, including the preservative. You see, freshness here cannot be precisely defined. Because when you say fresh whole blood, dapat na nakuha siya from the donor and na-transfuse sa patient within 8 hours. And most of our whole blood in the blood bank would be more than 8 hours already. So, madalang makakuha ng fresh whole blood. And they say that after several days, the platelets and granulocytes would be no longer viable, and the coagulation factor content, such as factor 5, 8, and 11, may be already low by about 80% after 1 to 2 days. No? Only factor 2, 7, 9, and 10, and fibrinogen are well maintained. So, for the above contents, when you say fresh whole blood, meron siyang red blood cells, meron siyang plasma, meron siyang platelet. But the contents would be questionable if it's not transfused within 8 hours. Usually, when this happens, they are divided already into component transfusion or stored in the blood bank as whole blood, not fresh whole blood. So we rarely transfuse fresh whole blood. There are few indications though, like patients who are actively bleeding, who have lost over 25 to 30% of blood volume. Those massively transfused patients meeting any of the following criteria, wherein there's active blood loss or blood loss exceeding 1 blood volume in a period of 2 to 3 hours, prior transfusion with at least 5 units packed RBC, or 20 ml per kilogram of packed RBC in pediatric patients. Okay? Whole blood is also used in exchange transfusion and autologous transfusion. Okay, platelet transfusion, we have two types. One is donor random platelet. This is separated by centrifugation from whole blood within 6 hours from extraction. So, usually, to make 6 units of platelet concentrate, this comes from different blood donors who are of the same type. That is the difference of platelet pheresis, because apheresis machine separates the platelets, turns the remainder of the blood from only one donor. Okay? So, ito yung, in the figure, you can see the platelet pheresis machine. It only comes from one donor. Hence, mas maganda yung quality ng platelet. And 1 unit of platelet pheresis is equivalent to 6 to 8 bags of random donor platelet concentrate. When do we use platelet pheresis? Number 1, if the patient would need HLA match because there's already platelet refractoriness. So ito yung sinasabi natin that a patient who develops platelet refractoriness or alloimmunization would not respond adequately if we transfuse in the future platelet concentrate, because there are already antibodies that will destroy the transfused platelet. Dito mas maganda ang platelet pheresis because it came from one donor. Mas maganda yung quality ng platelets. Okay? Second, of course, we want to reduce donor exposures. Okay? And then third, if there's a limited number of donor, mas maganda na platelet pheresis na lang yung gawin. So, for example, during this time of quarantine, there are very, very few donors in the blood banks. Okay? So, sa isang donor, if we use platelet pheresis machine, it will extract platelet that is equivalent to 6 to 8 units platelet concentrate. So, ganun kadami, diba? So, mas efficient siya. But the downside is the cost because it's around 12,000 pesos while the random platelet concentrate would be 1,000 per unit. So, kung 6,000, kung 6 units lang kailangan mo, that's only 6,000. So, doble ang platelet pheresis when it comes to cost. Some must-knows for the platelet lifespan and kinetics. Usually, the lifespan of platelet is average of 10.5 days, but the bone marrow makes platelet about 5 to 7 days. The residual mean lifespan of donated platelets is approximately 4 to 5 days. So, kung magpapareserve kayo ng platelet, always remember that there is an expiration date for the platelets. So, mas maganda yung kaka-extract lang na platelet because once it is expired, you cannot transfuse it anymore. It has a shelf life of 3 to 5 days and is stored 20 to 24 degrees Celsius under constant agitation or else aggregate yung mga platelet. So, ito yung mga nakikita nyo sa blood bank na machine na nagmo-move. It's it prevents aggregation of platelets. How do we compute the dose of platelet that we will transfuse? Number one, we have to know the weight of the patient because every 10 kilogram body weight of the patient is equivalent to 1 unit that we need to transfuse. So, for example, the average 70 kilogram person would need 7 units of platelet. The dose may be increased to 1.5 to 2 bags per 10 kilos in the following scenarios. When there's splenomegaly, because an enlarged spleen can sequester platelets. If there's infection, fever, and DIC, there's faster platelet destruction, so you need more platelets. So, pag ganon, sa 70 kilogram, pwede kang mag-transfuse as high as 14 units platelets. Okay? The expected response would be 5 to 10 times 10 to the 9 per liter per meter body surface area. The timing of repeat platelet count would be 15 minutes to 1 hour post-blood transfusion. And the platelet increment would be an excellent predictor of effective platelet transfusion. So, dun mo makikita kung meron bang platelet refractoriness yung patient. Kapag pinaulit mo, and then there is incremental increase in platelet, then okay yun. Guidelines for platelet transfusion. Number 1, a threshold of 10,000 is effective in preventing morbidity and mortality from bleeding in stable oncology patients undergoing chemotherapy. So, example of these patients would be patients with leukemia or patients with breast cancer who underwent chemotherapy using anthracycline like idarubicin. It's a myelosuppressive agent. So, we expect that platelet would be decreased in the nadir stage. Kailan tayo magsasalin, di ba? So, nakalagay dito that if the platelet count is 10 and there's no bleeding, then you may not transfuse platelet. But if it's less than 10, you can do prophylactic transfusion of platelets. Number 2, platelet count less than 10 to 20,000 in the presence of marrow failure and absence of clinical bleeding, you may transfuse platelets. So, yung mga pasyenteng may aplastic anemia or leukemia, threshold would be, some would be less than 10 or some would be less than 20. So, both are acceptable. Number 3, a platelet count more than 50,000 is desirable prior to invasive procedure and in the immediate post-procedure period. Okay. So, yung mga, there are patients who are referred for surgery, abdominal surgery, ano pa, yung mga excision, biopsy, wherein the platelet is low. So, sabi dito, sabi sa guidelines, if it's more than 50,000, then you may not transfuse. So, ang threshold is less than 50,000. Prior to procedure, kailangan magsalin. Number 4, platelet counts closer to 100,000 may be prudent for patients at high risk of intracranial hemorrhage, such as those with leukostasis or very high white blood cell or when undergoing neurosurgical and ocular procedures. So, an exception of platelet of more than 100,000 is given for high-risk procedures such as neurosurgical and ocular procedure or ophthalmic procedures. Okay? So, ang threshold mo, 100,000 or less bago ka magsalin. Fifth, prophylactic platelet transfusion is ineffective and rarely indicated when the thrombocytopenia is due to increased platelet destruction. So, an example would be sepsis, okay, or DIC. If there's no bleeding, it was seen that prophylactic platelet transfusion is ineffective. Hindi kailangan. So, we just transfuse if there's bleeding. Number 6, prophylactic platelet transfusion is rarely indicated in surgical patients with thrombocytopenia as long as pasok siya dun sa guidelines natin. So, more than 100,000 if it is a high-risk procedure, neurosurgical and ophthalmic, while the rest of the surgical procedures would need more than 50,000 platelet. 7. Surgical and obstetric patients with microvascular bleeding usually require transfusion of platelets if they are less than 50,000. Vaginal deliveries or operative procedures ordinarily associated with insignificant blood loss may be undertaken in patients with platelet less than 50,000. Okay? So, pwede pa rin silang undergo ng procedure even if they are a little bit less than 50,000. But you know, most of us would reserve platelets for possible increased bleeding at this level of platelets. Okay, let's go to another blood component. Ang pinagkakaguluhan ngayon, we have plasma for COVID. So, anyway, fresh frozen plasma comes from donated whole blood within 8 hours from phlebotomy. And whole blood is usually centrifuged, and then the red cell component is separated from the plasma component. It's rapidly frozen to negative 18 degrees in order to maintain a shelf life of 1 year. And then, if it is needed, then you would request the blood bank to thaw the platelet, and thawed platelet must be transfused within 24 hours by the AABB standards, while the FDA standards would be within 6 hours. What are the guidelines for FFP transfusion? Number 1, it's used for urgent reversal or warfarin therapy at a dose of 5 to 8 ml per kilogram body weight, especially if there is severe bleeding. Second is correction of known deficiencies for which specific concentrates are unavailable. So, an example of these are the hemophilia patients. Pag walang factor 8 or factor 9, then you can use FFP. Number 3, For correction of microvascular bleeding in the presence of an elevated PT or APTT more than 1.5 times the normal. So if there's a patient who has bleeding and the prothrombin and APTT is abnormal, then you may transfuse FFP. Number 4, for correction of microvascular bleeding secondary to coagulation factor deficiency in patients transfused with more than one blood volume, and when PT and APTT cannot be obtained in a timely fashion. So these are patients with massive transfusion, who receive massive transfusion, especially in trauma patients because there is dilution coagulopathy. So how do we compute the dose of FFP? It's usually 10 to 15 ml per kilo. So for example, 70 kilos yung pasyente. You multiply 10 ml times 70 kilos, that is 700 ml, right? And 1 unit of FFP would be around 200 to 250 ml. So, you would need around 3 units of FFP to achieve minimum 30% of plasma factor concentration. So, huwag kayong malilito ha. Ulitin natin, pag platelet, for every 10 kilo body weight, 1 unit. Pero pag FFP, 10 ml per kilo. So, 10 times 70 kilos, that's 700 ml divided by 250 ml per unit, that's 3 units. And then lastly, FFP is contraindicated for augmentation of plasma volume or for albumin correction. Cryoprecipitate is a portion of plasma. So, it's a plasma derivative that is rich in certain clotting factors. It's rich in factor 8. Okay? It's rich in von Willebrand, factor 9, fibrinogen, and fibronectin. So, saan siya ginagamit? Sa hemophilia A patient na walang factor 8 concentrate. And also sepsis, okay? Kasi nagde-decrease ang fibrinogen. It's removed from plasma by freezing and then slowly thawing the plasma. Once it's thawed, cryoprecipitate cannot be refrozen and may be kept at temperature 20 to 24 degrees Celsius for no longer than 6 hours. What are the indications for cryoprecipitate? One is treatment of patients with hypofibrinogenemia because it has high fibrinogen. Treatment of bleeding in von Willebrand kasi marami rin siyang von Willebrand factor. And hemophilia A patient because it has high factor 8. Treatment of refractory bleeding in uremia. And preparation of surgical adhesive or fibrin glue. How do we compute for the dose? 1 unit per 6 kilogram body weight. So, in an average 70 kilogram would need 8 to 10 units of cryoprecipitate. Next, we have granulocyte transfusions. We rarely use this. Actually, I've not used this. But granulocytes or neutrophils can be collected through apheresis. The indications are actually not well defined and there's no strong recommendations to its use. But it is considered in patients with severe neutropenia, wherein the absolute neutrophil count is less than 500, with fever, sepsis, and sepsis with an identified responsible organism. Okay. It should not be initiated for at least 96 hours after onset of clinical signs and symptoms of infection, because when you use antibiotics in these patients, targeted or broad spectrum antibiotics in these patients, they might improve. So usually granulocyte transfusions is reserved as last resort. The reason why this is not usually given because granulocyte transfusion are highly antigenic, so it can cause immune-mediated problems, and it's costly. That so you may use as an alternative would be granulocyte colony stimulating factor or GCSF. Almost always it's not used because the newer generation of antibiotics and GCSF are very efficient already in patients with infection and in patients with neutropenia. So now that you know the indications for transfusing these blood components, why should we be strict about transfusion and not transfuse by just a trigger of low blood counts? Why should we be judicious in giving transfusion? Because number one, there's limited supply. It is something that is not manufactured. Okay, if there's no blood donor, then there's no blood product that can be transfused. It has finite shelf life. Okay, transmission of infection, possibility of transmission of infection, such as Hep B, HIV, but now that we have more sophisticated tests, this has low incidence already. Antibody formation versus donor. Okay? The decision to transfuse, like any other form of therapy, should be based on risk, benefit, and alternative. And guides to therapy are provided but can substitute for clinical judgment of the physician. So it will fall in the end, it will fall in your hands, the decision to transfuse. So be wise and careful in deciding. Some practical guides to bedside administration. Number one, patient education and consent is a must. Before you order transfusion, you have to explain to the patient or the relative why are you transfusing and what are the side effects. Acquaint with transfusion, the process, and encourage and promote voluntary blood donation. Second, venous access must be ready before release of blood because as we can see, especially the plasma products, they have a shelf life of around 6 hours when thawed. So, if you will insert IV line prior to, then it will eat up the hours outside the blood bank. Third, only red cell component and whole blood need cross-matching. You don't need to cross-match platelet, plasma, cryoprecipitate. Their main requirement is the same blood type but not cross-matching. Fourth, administered blood as soon as released from the blood bank. Fifth, it cannot be stored in unmonitored refrigerators. Okay? And use of filters is a must for blood and components. Blood transfusion set cannot be used for the subsequent IV infusion. So, iba yung IV fluid set sa blood transfusion set. It should be discarded after use. It cannot substitute. Second, blood warmers are not necessary except for very rapid infusion of blood. The compatible IV is only plain NSS or 0.9% NaCl. The others, hypotonic or hypertonic, would lyse the red cells. No medications can be added to the blood. Okay? Dapat stand-alone siya or only with plain NSS. And then, routine pre-medications is not necessary only in patients with high risk for allergic transfusion reaction. Do we give pre-medications such as antihistamine and paracetamol? Infusion rates of blood components may vary. So, meron dyan mga fina-fast drip, merong hindi. For PAC-RBC, they are transfused 4 to 6 hours. For plasma, platelets, and cryoprecipitate, if there is no risk of pulmonary congestion, then it can be given as fast drip. But if there is congestive heart failure or renal failure, then you have to give it more slowly, 1 to 2 hours. Transfusionist is the last point for detection of error. So, transfusionist must review physician orders, recipient and donor identification, and compatibility, unit expiration date, compatibility testing, and the physical appearance of unit of the blood prior to transfusion. So that's the end of my lecture. I hope you would be encouraged to donate because if 10% of the population will donate, we will have enough blood products to serve the needs of our patients. Remember that our population is 106 million, and we only, if only 10% of that, that's only about 10 million. Okay? So, I hope you will donate. These are the requirements. You should have a valid ID. There's no alcohol intake in the past 24 hours, no tattoos, no ear piercings, at least 18 years old, and at least 50 kilos. For menstruating females, usually 1 week after or before the 1 week after the menstruation would be the right time.